Hi there. I'm 59. I've recently been diagnosed with osteoporosis, and they said I'm young for that, which I agree. The doctor wants to put me on Alendronate. I don't know if I'm saying that right. ALL.
Alendronate,
you know
yes.
what it is. They also prescribed calcium carbonate. I'm sure you know about this. What is your suggestion?
Well, it's not my favorite.
Well, yeah, but it is one of the oldest in the...
It is. Been around forever.
Oldest class of drugs for treatment of osteoporosis and osteopenia. So how bad is your osteoporosis?
-3.
Oh, okay. And is that in the spine or the hip?
I think he said, he didn't specify. It was down at Madigan. I think he said it was in the hip because that's mainly where they took pictures of when I did that scan thing.
Okay. Let's talk about osteopenia and osteoporosis. Obviously, it is a common problem. It happens as we get older. And what it is basically demineralization of bone and loss of bone. So when you're younger, weight-bearing activities and also hormones, estrogen and testosterone particularly, tend to lay down bone, make it stronger, and prevent the resorption of bone. But as we get older, cell turnover changes. There's not enough testosterone or estrogen to help lay down more bone. Testosterone particularly lays down bone. Estrogen prevents resorption of bone. And when you reach, perimenopause and then into menopause and postmenopausal age groups with the declination of these hormones, then the rate of bone resorption increases, which basically means the bones become thinner and weaker. And the reading is that, after you get to -2.5, then they classify you instead of osteopenia into osteoporosis. And so at osteoporosis, the bone is really weak and fragile, and the risk for a break in that bone with minimal trauma is high. So if you were to fall, you would probably fracture that bone. So then the question is, what do you do to help maintain the strength of the bone and prevent a further problem, which is a fracture? Because if you sustain a hip fracture, statistics are that 1 in 2 will require some help after that fracture.
For the rest of their life.
For the rest of their life, yes. And so we have our thoughts on that. Obviously, we're at longevity and believe in prevention. And so the most natural thing you can do for that is hormone replacement therapy. Both testosterone and estrogen will prevent the bone from resorping and will help heal it. Now that it's gone this far, though, it's a little bit harder. That's why you're actually a shoo-in for our earlier dialogue about prevention. Had you, continued with the hormone replacement therapy, then maybe this would have slowed down, delayed it, or even prevented its progression because you would still be laying down healthy bone. But now, at -3, the question is, what is your preference? Now, it's a toss-up.
Yeah, the problem is that the testosterone stimulates new bone growth, and the osteoblast, the cells that make new bone, are stimulated by testosterone. Testosterone also is a stem cell protector.
Yes,
it allows you to keep the stem cells that let you grow new tissue, all new tissue, bone marrow, bone, muscle, all of it. The estrogens that you had in your youth were protecting you against bone loss. And so as you've aged, your testosterone loss means you're making bone slower. Your loss of estrogen means you're dissolving bone faster. And that combination of making it slower and dissolving it faster results in negative bone density. Things go down and down. We can kick things back into gear to make bone again, but that's a slow process. That would mean we would have to reverse your process, and it would take a few years to get you there. With the alendronate, we can actually make a harder bone within about 6 months. Now, it won't be...
What did you say with the what?
With the Fosamax, the Alendronate, the bisphosphonates. That's the first class of drugs that came out.
Bisphosphonates are the general class of drugs that these...
That Alendronate is. It's basically Fosamax.
And so this doesn't make normal bone. It makes harder bone.
Stronger bone, yeah.
The outer cortex of the bone gets stronger and more rigid. It
Yeah.
doesn't have the flexibility of natural bone. And if it breaks, it doesn't heal as quickly or smoothly. So it's less likely to break because it's harder. You get an abnormal but stronger structure to the outside layers of the bone. The inner layers, that matrix, it's a trabecular matrix on the inside of the bone, continues to fade away. These drugs do not make healthy, normal bone.
Mm-hmm.
But the bone is stronger. And so if you fall, you're less likely to break it. If you do break it, on the other hand, it doesn't tend to heal as well.
Right.
So it's, like everything in medicine, it's a plus and a minus.
And the drug has side effects.
And the drug, it does indeed have some side effects. So we prefer to involve people before you get all the way down to a 3.
Right.
So we have more time so that we can actually grow healthy new bone and not have to make these decisions.
Right. There are newer class of drugs that are IV therapies, but now you're kind of stuck in the insurance quagmire where you have to show, or actually your doctors have to show that you tried one and didn't tolerate it before they could give you some of the more expensive medications. If the question is, would you consider treatment or would you wait for HRT? And that's really a very difficult question and very personal one. So you have to weigh your own risk versus
do both.
benefit. Well, definitely you can do both. Yes.
You can use the bisphosphonates on the short term to give yourself the faster protection.
Yeah.
While then using the longer term solution with the testosterone and the estradiol to give you longer term, healthier bone.
Yeah. I have 80-year-old women in my practice that have osteopenia, and we have slowly maintained their osteopenia and, gotten them from minus 2.0 to minus 1.8, minus 1.5. We haven't gotten them back to baseline, but again, they are also getting older.
Yeah.
And so the hormones do help, and they will do the job. But if you're already at minus 3.0 at least one site, if not multiple sites, then your risk for a fracture is high. But given your age, you can talk to your medical provider and see if they would consider hormone replacement therapy for you.
Mm-hmm.
There are estrogen patches that can be used that are exactly the same as a physiological estrogen.
Mm-hmm.
And so I'm not opposed to that at all, but you'll have to have that conversation with your medical provider. They are okay with estrogens. I have never seen anybody replace testosterone.
No.
But at least it's something and it's better than nothing.
Exactly. Now, my knee is healing very slowly. My knee replacement, I had it going back in July.
Mm-hmm.
My doctor thinks that maybe one of the reasons, some people heal really fast from knee replacements and some people don't. Could that be a reason because of my osteoporosis, why my knee is?
Yeah, sure. You're not growing new bone. You're not healing bone very fast. In fact, you're losing bone every year.
Got it. Okay, so what are some of the major side effects of Alendronate?
Well, the biggest ones are GI side effects. It causes severe heartburn, so they basically tell you not to lie down after taking it. You have to stand upright or sit upright for a while. And then the osteonecrosis of the jaw. That one is a big one. The dentist will always ask you, what drugs are you taking before they manipulate anything in your mouth?
Yeah. If you had to have a root canal or something, you could trigger basically having part of your jaw die.
Fracture,
Yeah. And the rules are you stay upright, you don't take it with anything except plain water.
Yeah.
Make sure you drink enough water to get it all the way through the esophagus down into the stomach, because if it doesn't go all the way down, it can cause ulceration and irritation in the esophagus. It's an irritating drug. It does have its downsides, but the good news is within 6 months or so, you will at least have a harder bone that will not break as easy.